Hi, my name is Dr. Michelle DeGrazia. I'm the Director of Nursing Research for the Neonatal ICU at Boston Children's Hospital. Today, I'm very pleased to welcome Dr. Cinda Rushton. Cinda Rushton is the Anne and George L. Bunting Professor of Clinical Ethics in the Johns Hopkins Berman Institute of Bioethics and the School of Nursing, with a joint appointment in the School of Medicine's Department of Pediatrics. She is founding member of the Berman Institute of Bioethics. Dr. Rushton co-chairs the Johns Hopkins Hospital's Ethics Committee and Consultation Service. An international leader in nursing ethics, in 2014, Dr. Rushton co-led the first National Nursing Ethics Summit convened by the Johns Hopkins Berman Institute of Bioethics and School of Nursing. The summit, supported by strategic partners from 9 national nursing organizations and 7 collaborating organizations, developed a blueprint for the 21st century nursing ethics. Her current scholarship in clinical ethics focuses on moral distress and suffering of clinicians, the development of moral resilience, palliative care, and designing a culture of ethical practice. Welcome, Cinda.
Thank you. It's really a pleasure to be here.
I would like for us to start by you telling me what served as a catalyst for you to work on the subject of moral resilience.
I have been working for really decades around issues of moral distress. And I had an opportunity to be a visiting scholar at the Brochure Institute in Geneva, Switzerland. And having a space to kind of pause and look at all the literature and, where I'd been, I thought I was going to write a book proposal on moral distress. In my research, I had come across a few articles where the concept of moral resilience had been mentioned. And I thought, wonder what that is. And so then that led me to actually collaborate with some colleagues to first of all, do a really extensive review of the literature, and we found there were only like 15 or 16 articles where it was even mentioned, and not really well defined.
It's really surprising to me that there was such a paucity of articles or literature that describes moral resilience.
Well, I was surprised too. It's very clear in the literature. There is a large amount of literature on resilience in different contexts, so biologic resilience, psychological resilience, social ecological resilience, so how do communities respond to things like adversity? Sure. But in the moral domain, there really wasn't much. And so I sort of took on the project of trying to think about what is unique about the moral domain, and how do we think about cultivating that capacity within ourselves. So in the work that I've done, I've borrowed from the general resilience literature. Much of it is oriented toward response to adversity. So in the case of moral resilience, it's moral adversity, the kinds of things that actually challenge our sense of integrity as a person. And then looking for ways that we might leverage what's been learned in those other domains into this specific domain of moral resilience.
What kinds of situations, for instance, lend themselves to moral distress in nursing?
So there's a really quite a lot of literature that documents the causes, the sources of moral distress. And I think they're pretty familiar to us as pediatric clinicians. There are things that revolve around end-of-life care, where we feel like we are causing more harm than good, or where we're implementing decisions that may not be in the best interest of the patient, and yet their family is requesting them. There are instances where we feel that maybe there hasn't been adequate informed consent, that maybe not all the possible options have been disclosed for one reason or another. And nurses are often very attuned to that.
Right. And caught in the middle of those situations sometimes, and have to make some decisions about how they will respond to those concerns if they are caught in the middle. Right?
Absolutely. All of the sources of moral distress, in one way or another, arise from the role nurses have. And as you say, nurses are typically not in the position of making the decision, but they are in the position of carrying it out. Right. And I think that is a unique perspective on how we provide care. That sometimes there's a sense that the physician who's making the decision is taking on the moral responsibility for the whole team. What that misses is that nurses have their own individual moral agency. Right. That also counts.
And we need to partner with the physicians to carry out the care, and also carry the load of the decision making too, right?
Exactly. So it's acknowledging both of those dimensions, and I think that makes it particularly problematic in an environment where we have burgeoning technology. We have situations where we have chronically critically ill children who live in our intensive care units sometimes for months. And with that, I think confusion around the boundaries of parental decision-making and how shared decision-making actually ought to look in our clinical practice. There's a sense that clinicians feel like now we have to do whatever a family says, which has some real costs to it as well. And so I think in pediatrics in particular, reimagining and reconceptualizing what shared decision-making is one of the areas where I think there might be opportunity to see if we can find a new way forward. That is collaborative, that is respectful and compassionate, but at the same time acknowledges the important contribution that everyone makes in that process.
We'd like to stop for a minute now and ask our viewers a question. When you respond, please leave your city and country location. The question is this: reflecting on your own practice, what are the sources of moral distress in your institution? Once you were in Geneva and you recognized that there was such a paucity of information on moral resilience out in the literature, what were your next steps? Where did you go from there?
So the first thing we did was actually do a very comprehensive review of the literature to validate that conclusion, and wrote a paper that highlighted the existing definitions and did some, analysis around that. Then the second piece was we collected 184 definitions of moral resilience from interprofessional clinicians. And we asked the simple question, what does moral resilience mean to you? And so we analyzed them and did a content analysis of those and came up with 6 dimensions, themes from the data. What we found was that the 6 themes are, first of all, personal integrity, relational integrity, buoyancy, self-regulation and self-awareness, moral efficacy or competence, moral competence, and self-stewardship. The overarching theme is the theme of integrity. And what was interesting about that is that integrity includes 2 aspects: personal integrity and relational integrity. Personal integrity is, when you look in the literature, the way we mostly talk about integrity, that sense of wholeness and harmony, of being undiminished, of being able to live your values and to, sometimes have to make hard choices to preserve your integrity.
Right. And being happy with yourself, right?
And being able to live with that,
yeah.
But what was interesting is there was also a second dimension of integrity, and that was what we called relational integrity. In the definitions, there were some very clear themes about clinicians saying, I need to be true to myself, and I need to acknowledge that in my role, I have to work with and implement decisions that may not be what I would choose. So how to be whole in the midst of a context where there's differences of views.
Right. Can you give an example of that? Because I think for some people that might be a difficult concept.
So think about being in a clinical environment where there's a conflict, maybe about goals of care for a child, and parents are asking one thing. Maybe there is disagreement among different specialties, disciplines. Nurses and doctors may not see the situation the same way. So if, for example, I come into that situation and I am able to remain grounded in my values and to be clear and open to other points of view, it influences the way the rest of the team is going to show up.
Okay.
As opposed to when we come in and we are very attached to the only way to get through this situation is to convince the family to agree to a DNR order. And underneath that is a lot of judgment and negativity. Then the likelihood is that other people are going to resonate with that as well.
Okay.
So I think it's, in a way, it's subtle, but in another way, it points out why, as groups of clinicians, we really need to collaborate and have reflective spaces where we can open up those conversations to increase the likelihood that we can all act with integrity and acknowledge that integrity for the physician may be different than integrity for the nurse, but both matter. The other dimension of that is when we bring our voice forward to speak about things that we believe are undermining our integrity, it doesn't mean that the only way we can measure our success is whether we get the outcome we want. So it matters, first of all, from the point of view of integrity, that we recognize there's a moral problem, that we've taken action, we spoke up, we brought the issue forward. And that effort matters as much as what the ultimate outcome is.
So we've talked a little bit about integrity and the relational part of moral resilience. What is the next one? Buoyancy, you mentioned?
So buoyancy is a very interesting concept of, a lot of times we think about resilience as being able to bounce back. And that's certainly true, that it's like being able to ride the waves where you can kind of, things happen, but you're able to kind of get your grounding back. You get back to a place where you feel whole. And that is a very important part of being morally resilient. So when a ethically challenging situation occurs, you are affected by it. You may be distressed, but you're able to get yourself back on course. In addition to that, there was a very interesting sub-theme in these definitions about not only bouncing back, but the idea of bouncing forward.
Interesting.
That there is an opportunity in response to moral adversity to learn, to grow, potentially even to change in positive ways, to make meaning out of the situations that we find ourselves in.
So as you learn from experiences, then you're building on your knowledge about how to deal with these types of situations, and you get better at it.
And also to see the possibility that even in the midst of these really challenging, difficult situations, that we can find the evidence of possibility for what we might learn about ourselves, what we might learn about each other, what we might learn from the patient or their family, that we could use those opportunities of adversity to learn and also to learn about our systems. So having processes in place where we routinely, when a difficult case has occurred, that we go back and do a kind of root cause analysis to say, how is it that we got here? And what were the factors in the system that contributed to the conditions that caused this to happen?
So it really requires that you look at these situations very critically.
Yeah.
And I like the idea of your suggestion of going back and looking at these situations and doing that evaluation. Much like we do with, a unique medical situation, right? So it's not about this time, it's not about the diagnosis necessarily.
Right.
It's about how we worked as a team to deal within this ethically and morally challenging situation. And how did we manage to maintain integrity as a group or not?
I actually, when I think about it, most clinicians I know already have a lot of capacity in being buoyant. There are just some situations that overwhelm their ability to be able to stay in a zone of resilience. So the next piece in terms of thinking about moral resilience is this idea of self-regulation and self-awareness. And these two kind of go hand in hand because being able to be buoyant means that you've got to have skills in self-regulation. So noticing when you have become very agitated, angry, anxious about a situation is an important skill to have so that you can perceive the ethical question clearly without a projection, without reaction, but actually see it as it really is. And those skills are very important in terms of just managing the intensity that we feel in response to either real or perceived violations of our integrity, where an important ethical value is at stake. And we may feel even morally outraged about the situation. Moral outrage is an important indicator that something very important is threatened in some way. The challenge is that when we are morally outraged, often we are reacting from the most primitive part of our brain. And what we want to be able to do is to find ways to pause and self-regulate, to discern what is the best and most constructive path I can take in response to this.
And that makes complete sense when you think about it. I mean, when you're confronted with a situation that's difficult for you, you need to do something about it and take action, but you need to think about what that action the best course of action might be, right?
Exactly. So if we can actually calm our nervous system down, then we can have an opportunity to more clearly discern what would be the right thing.
So now let's talk a little bit about moral efficacy. Tell us about that.
So this idea of moral efficacy is seeing oneself as capable of addressing ethical concerns, challenges in a way that reflects our integrity. It's the knowledge, the skills to recognize ethical problems, to be able to discern what is important in those situations, to detect, what pieces of information are important, and also to have the skills and reasoning to be able to look at the various options that are available from an ethical point of view and to look at the reasons why they are permissible or not, to be able to understand the trade-offs that we're making and the consequences of those. And it also involves this very important aspect of actually taking action. It's not enough to just know what's right to do. You also have to have the courage sometimes to do the right thing.
So give us an example of how that might happen.
Think about, a situation we're talking about where there's disagreement among the team. And, one of the elements or ways of thinking about moral distress is that you recognize there's a moral problem. You have responsibility to do something about it. You've reasoned that you think the right thing to do is we need to stop this aggressive life-sustaining therapy. So you've come to your own conclusion. However, then, now you've got to negotiate that in the context of relationship.
Right.
So if you come into that situation and your approach is one of, I'm insisting that the only way that this can happen in a very aggressive way, it may be that there's merit to your point of view, but the people who are receiving your point of view may not feel engaged in trying to think it through or to consider another pathway, and they may become very defensive.
Yeah. And that can shut down communication if that delivery is not good.
Absolutely.
And then people stop talking.
Right.
Which is not going to help anything.
Right. And people then feel more isolated and powerless, and it creates this whole spiral of negative feeling.
Yes.
And it leads really easily into the final concept, which is self-stewardship. Because this idea of we have a responsibility first to know ourselves, and that includes knowing our limits, knowing what we are actually capable of, and when we are reaching a point where continuing to do what we're doing may actually cause harm to us or other people.
Right.
So this idea of self-stewardship is that we are responsible for stewarding our scarce resources within ourselves.
Let's talk about the next steps here. Once you got this definition, what are you doing with it now?
The next thing that we started focusing on was concerns that came out of the data in our own institution, but nationally, about the numbers of particularly new nurses that were leaving either their jobs or their professions after a year. And our dean was very concerned about that and allocated some funding to develop a program to address that. So we developed the Mindful Ethical Practice and Resilience Academy, MEPRA, and it is a 6-session program, 4 hours each, for new nurses and nurses who've been in practice for many years. It's a sort of combination cohort. It is a program that is focused basically on 3 areas. First is a foundation of mindfulness. So developing skills to use mindfulness practice in response to ethical challenges. The second one is to develop moral efficacy, ethical competence. And the third is resilience. And so we've developed this program. It's a very experiential program. And in that context, we explore things like what our moral compass is, why we are a nurse, bringing us back to our values and intentions. And then we explore things like empathy and perspective taking, the role of bias and assumption in our work, how we begin to recognize ethical problems, so the idea of moral sensitivity, and then how we reason about complex cases. And we sort of unpack that in a way that we're sort of looking at all the elements in a more consistent way. We also then explore this question of moral suffering and moral distress and how it affects us, and then how we can use some of these tools to respond to those situations. One of the big themes in the program is around communication. And communication is a place where I think nurses can become mute. They can become feeling so disempowered that they don't think their voice matters, or they don't know how to bring their voice into the conversation. So we actually work on that whole continuum. The idea that I belong here.
I know some of the work we've done here, one of the themes that came out of research on moral distress was that no voice. So you're really taking the next step and helping the nurses to get their voice again.
Yeah. So we do that in a variety of ways. We do role play, but one of the important elements of this program is in the 5th session, we go to the simulation lab using high fidelity simulation, and we simulate conversations that the nurse has to bring a concern to a clinician. And it's not an easy conversation. So they have to apply their skills in self-regulation, how the words and their body language, how that shows up, how they communicate it in a sort of organized format. And then they also do a simulation of a difficult encounter with a family member to apply it in a somewhat different context. But how do you use those same skills in that circumstance? It's been just amazing to see how, first of all, they've been able to actually integrate and apply these concepts. And at the end, it leaves them feeling capable.
Yes.
Like, I can do this. So we now have over 100 nurses who've been through the program. We have a 5th cohort that is starting soon. And at the end of the spring, we'll be doing data analysis of all the pre and post evaluation. Our early trends suggest improvements in work engagement, ethical confidence, and competence. And it looks like trends toward changes in both resilience and mindfulness. So we're very excited about that and about the sort of prospects for what that might look like in the future. The other thing that we are working on, I have 2 amazing postdoctoral fellows who are working on the development of an instrument to measure moral resilience, because there aren't any.
Right.
And so we've taken our content analysis and organized that instrument based on those 6 themes. We've already sent it out for expert review, and we're about to start doing focus groups and then validate it hopefully this spring, so that we'll have an instrument to measure moral resilience. We're doing it in an interprofessional context. So it's not just a nursing-focused instrument, and also going to be testing it in both adult and pediatric settings.
Let's take a moment now and turn to the audience. In your answer, could you please state your city and country location? The question is, can you share some examples of specific interventions your organization is implementing to foster a culture of integrity and moral resilience? So, with that in mind, what are your next steps?
Our next steps are really looking at how do we take this MEPRA program that we've developed and how we can begin to create a systems approach to learning, creating learning communities, looking at how we engage different levels of our leadership. We just had a meeting with nurse managers to engage them in thinking how they might support these new skills in their staff. We're really looking at it as well from the system perspective, because you have to have individuals who are personally more morally resilient, but you also have to have organizations that are creating a culture that supports ethical practice. They have to go hand in hand. It's not one or the other, it's both.
Cinda, thank you so much. That was so well said. And I just want to, we really appreciate having you here today and discussing this very important topic for open pediatrics. Thank you.
Thank you.